So good evening, friends. Sorry for being late, and thank you, Bharti, for giving me this opportunity. And thanks the chairpersons. So I'll be talking about the clear lens section at 50 years old male. So what are the issues when we are trying to remove the lens? Is it safe? Do we have the accurate biometry possible? Can we take care of the astigmatism? Can we take care of the presbyopia? Can we manage the complication and comparison with the IPCL? So we know that this surgery is absolutely safe with the improved fluidics. Power delivery is hardly any in these cases. Anesthesia is topical, so there are no chances of globe perforation. The eye square is very few patients need the yak capsulotomy now. Accuracy of the biometry has improved so much that we are sure to have 85% of the patients within 5.5 diopter of the post-refractive error. And astigmatism is well established, and excellent results now can be achieved with the toric IOL. Even up to the now, the toric IOLs are available, which can correct up to 0.67 diopter of astigmatism. Beyond one, we used to always correct. And so far as the presbyopia is concerned, there are multifocal, trifocal, and EDOF lenses, mini monovision, micro monovision. So there are many ways to make the patient spectacle independent. And I'll show you one of the things, like suppose you are using a synergy, which type of a lens, which is gives 0 to 33 centimeter of a distance, full range coverage. If you are using symphony and vivity type of a lens, it gives you intermediate and a distance. If you take the premium monofocal, it gives you around 0.5, 0.75, and the monofocal just at one point of time. So whenever, whatever lens you are using, there has to be a combination in that. So whenever you are using a synergy lens, never target the myopia, because then the near point will come too close from 33 to 25, which will be uncomfortable for the patient, and patient will have less vision. But even if it is a plus 0.25, he will have excellent vision for distance, and is from 33 to becomes 37. So whenever you are using the high powered near lenses, always target around little plus or emmetropic, very close to plus minus 0.25, not beyond that. While on the other hand, you are using symphony and vivity, you can have patient little bit of a myopic. If it's slightly myopic, his range, which is around 60 centimeters, 70 centimeters, will come closer, and he will be able to read better. And you can also target one eye at a distance, another eye little minus 0.5 to give him the full range of vision. And whenever you are looking at a premium monofocal, if patient is wanting only best distance vision, then you use it as a synergy. That means one lens may be a little slightly, even on the plus side, it will give excellent distance vision because it has got a landing space over there. So use it, and if the patient wants a little bit of intermediate vision, then use it like a symphony and vivity, that one lens becomes minus 0.25, another becomes minus 0.75, so that he can have easily, and with the addition of 0.5, 0.75 of the lens, patient can cover up to 60, 70 centimeter very well for the intermediate range. And we know that the monofocal lenses depends upon, again, there are the two types of lenses. Use it like a synergy, that means absolutely if he wants for distance, and you can have a mini monofocal to give the patient a near vision as well. So irrespective of the type of the lens and the patient's affordability, you can make the patient's spectacles independent depending upon his need. The only complication of the myopia is the retinal detachment, and there are AO guidelines that if there is asymptomatic lattice with or without holes, operculated atrophic holes, no treatment is required. Monthly follow-up for the first 3 months, 3 monthly follow-up for 1 year, and 6 monthly follow-up. Symptomatic PVD with no breaks, no treatment, 1 to 8 weeks, then every 6 to 12 months. So that means there are guidelines. If you do the myopic lens exchange, you have to follow these patients at least for 2-3 years very regularly and sincerely to look for the retinal detachment. And pseudo-myopic eye is 3 to 6 months. So you got to look for, and once the PVD develops, then chances of retinal detachment becomes much less. Most of the myopics will have a PVD over there. On the other hand, whenever you are getting the hyperopic patients, then it is absolutely a plus point because the IPCL may not be a good choice, particularly if it is shallow. These patients are more predisposed to glaucoma, and this gives the best outcome, particularly if the patient is slightly hyperopic. He'll be more than happy because his distance vision, near vision can be taken care of, and the incidence of glaucoma also goes down. And the complication of retinal detachment, CME, CMM, all these are minimal in hyperopes as compared to the myopes. So the problem of the phakic IOCL, the cost, the chance of glaucoma, chances of inflammation, infection, retinal detachment, halos, cataract development, endothelial cell loss, all of them are more than the cataract surgery so far as the IPCL is concerned. So halos in optic diameter of 4.9 millimeter, size of ICL which is 12.1 size, and 5.8 is the optic size when the IPCL is 13.7 millimeter. So the smaller the lens, more chances of halos in these patients. And there are more chances of the cataract development in these patients, and there are more chances of endothelial cell loss, 1.8% cell loss per year. In 3 years, 8.9%, 5 years, 11%, and 6% they lost nearly 30% of the endothelial cells over a period of time. So to conclude, RL is a good option, particularly for LASIK and ICL unfit patients. If the age is above 45, this patient is at 50 years of age. Hypermetropes, it gives the action results. Myopes, you have got to be careful, and regular follow-up is required so that the patient doesn't develop the detachment. And if it develops the detachment or the holes, it can be treated timely. And toric, multifocal, trifocal, monofocal, mini monofocal, there are many choices available to us to make the patient spectacle independent. And this is lifelong freedom from spectacles, and the patient won't have to go for the second surgery of the cataract. Thank you very much for your kind hearing.
Thank you, sir, for the fantastic talk.